the webinar, let me introduce myself. My name is Yana Gorbatenko, and I lead the IFC advisory work in healthcare sector across the globe. And as people are connecting, I would like to start with a few housekeeping remarks. First of all, today's webinar is offered in English, which would be the core language of the webinar, but also we have an interpretation function into French. So if you're interested to listen to this webinar in French, go to interpretation button and choose the French channel. Secondly, I would encourage this webinar to be interactive with engagement of participants. And for that, we have two functions. One is a chat function. So please introduce yourself, where you are. I'm sure in this community of people who join IFC Health webinar regularly, you may see some familiar faces. So use chat, share your reflections, comments, and so on. Secondly, the question, and you are able to see the question button, Q&A button at the bottom. If you would like to put your question to one of the panelists member, please write it there, and then either live or in a written space, we will make sure that we will respond to this question. So back to our topic. So IFC recently completed our second full round of healthcare benchmarking, and today we're sharing insights. The scope of benchmarking covers financial, operational, quality and patient safety, and select aspects of the clinical practice. And today we have a very interesting panel, a mix of IFC global healthcare team and some of our clients and partners from Europe and Africa, who would share their reflections in terms of like what they have learned through benchmarking and how they have applied it in practice. So what would be our run of the show? We'll start with the opening remarks by Zeynep Kantur, who is IFC manager for Global Health Solutions and Impact Unit of the Knowledge Bank, and she's responsible for IFC's work in the health sector globally, which spans on investment, advisory, as well as scaling effective solutions across public-private interactions in healthcare. We have IFC Principal Health Specialist Charles Dalton, who would share the key insights of the benchmarking. And then we have two panelists, Dr. Austin Okogun, who is CEO of Lilly Hospitals in Nigeria, and Dr. Sandra Morovic, who is Chief Medical Officer of Arsano Medical Group in Croatia. So we'll start with opening remarks. Charles will go through the presentation and then we'll discuss. And again, if something caught your attention, please let us know through either chat or Q&A. So Zeynep, with no further ado, I pass the floor to you to share your opening remarks with participants.
Thank you, Yana and colleagues. It's a real honor to open this session. And I'm so pleased to welcome many participants from across the globe. I'm going to try to keep this brief because you're in for a real treat today, as Yana walked you through the run of the show to hear some valuable insights and hopefully have a lot of conversation around this important topic. I wanted to start by sharing with you, many of you may have heard that the World Bank Group has set itself an ambitious target to reach 1.5 billion patients with affordable quality healthcare by 2030. And according to our calculations, business as usual is not going to get there. We have to put together an implementation plan to achieve this target by going beyond our business as usual and taking a mixed health system approach. So what does this mean? Is that the World Bank Group is going to be doubling down its efforts to strengthen the policy, regulatory, and investment environments that will enable the required interventions and, most importantly, health financing solutions to get affordable quality healthcare to patients. Now, with about 40 to 70% of health services delivered by the private sector in our client countries, we as a community have an enormous opportunity and a responsibility to play a key role in meeting this goal. And most importantly, getting affordable healthcare where it's needed, while also supporting job creation and economic development through building healthy healthcare industries. So that's the IFC strategy and goal. So as you know, for many years, we've been striving to be a lot more than just a financier in the sector. We have been building up our advisory and knowledge initiatives, including ethical principles in healthcare, IQ Health, our health advisory and awareness tool, a digital transformation tool, and the healthcare benchmarking tool that is going to be the focus of discussion today. And at this point, I would actually like to thank the government of Japan that partnered with us on many of these initiatives, including the healthcare benchmarking initiative. Japan has been an incredible partner to us in being able to expand our reach and impact. And we are taking a balanced approach, and I'm sure your institutions are as well, to managing performance through increasing clinical excellence, operational efficiency, and patient safety and quality of services. And all of these factors translate into financial sustainability and good business for the healthcare institutions we work with, and most importantly, better care for patients, which is our ultimate goal. This program was piloted back in 2021, and now it has brought together 182 healthcare facilities across 30 countries. The analysis spans across finance, operations, quality assurance, and clinical practices. And in this last round, we've also piloted benchmarking of clinical outcomes for maternity. And why have we initiated this project? So for several years, our clients, you have been asking us, how do I identify, how do I compare myself to other healthcare facilities in other markets? And how do I identify areas of improvement in my financial, operational, and quality results? We also frequently see many project proposals, many very valuable, impactful project proposals, but sometimes we to get to ramp up very quick few years. Sadly, these things don't happen, and important planning for healthcare investments is very important to achieve the sustainability and impact. So we would like to be more proactive in terms of enabling the new projects also to benefit from this data to create business plans with realistic expectations. It was also very interesting to see that the 2025 round demonstrated major variance in asset utilization, which can translate into more patients receiving healthcare from these same institutions. For example, the data on maternity clinical outcomes pilot indicates that the level that is achievable by best performers still shows room for improvement for many institutions. So today's webinar is going to share main findings from this year's benchmarking round, and then we'll explore what this data reveals about the current trends, performance drivers, areas of growth in the healthcare sector. Our goal is to equip you with actionable insights that can help your institutions. So it's very important, going back to Jana's invitation, that we keep this session interactive. When you hear things that resonate or don't resonate, please come in. And I'm looking forward to a very lively conversation. Thank you so much.
Thank you, Zeynep, for kickstarting us. And without further ado, I'm actually passing the floor to Charles Dalton, who would walk us through all the major insights that we have got. Obviously, there are tons of data being collected, but some of the zoom out conclusions that we have got. Charles, please, over to you.
Yeah, hopefully you can hear me okay, Jana. Just checking.
All is well. And
okay, thank you. Okay, perfect. Thank you very much. So I'm going to spend the next 20 minutes just walking through the sort of the oversights and key insights from the sort of the 2025 round. I'll give you my views. We are then going to have the panel discussion where we'll discuss them, but also please feel free to put any questions you have in the Q&A section and we can respond to that as we go. I really want to start off by saying thank you, okay? And I want to thank you all for attending today. I also want to thank the participants in this round of the benchmarking for making it so much bigger and so much broader, and for the active dialogue. And I also want to thank the IFC team in the background, who have been doing all the number crunching to make this possible. So a big thank you to everybody. So just repeating really what Zeynep and Jana have said. So this is the third iteration. The pilot was the first, and then this is now the second iteration after the pilot. And as you can see here, we sort of had 53 companies participating from 30 countries with 40,000 data points analyzed. So that's giving us an incredibly rich source of data that we're able to look at and then give this information back to each individual participant, and then also discuss it today in this group setting. Here, just a quick snapshot. You can see this geographical spread across the markets that we operate in from the bank, and hopefully in 2027, when we do the next iteration of this, we're going to see more colors on the screen, and hopefully we can get to 50 countries. So I just really want to set context, and I think all of you know that governments across the world are striving to achieve universal healthcare coverage. I think we all know it's a very mixed response. Some are doing relatively well, others are struggling. What is very clear is that the private sector has a key role to play. And it may vary depending on the country's circumstance, but absolutely that we know that the private sector key goals to achieve UHC, because there's no more money in the pot. We have to be more, we need to be smarter in how we spend each dollar. So we need to get more value. And by value, from my personal perspective, is better cost, better quality, better outcome. So we need to increase overall access to care. We also need to increase the efficiency and the utilization of the care provided, increasing the quality of care. And we're going to see in the results today that high productivity doesn't impact quality. In fact, those doing high productivity services are able to maintain high levels of quality. And then also we need to understand, how do we spend efficiently? And this is both a public and a private sector issue. So the private sector is continually being challenged to provide quality aligned care, but with more value. So those of you that are working in markets with a heavy insurance penetration, you know that the payers are trying to eke out more value for every dollar that they're spending. So the benchmarking program has highlighted in the conversations that we have when we give the feedback to each and every entity, i.e. all 50 entities, is the importance of performance improvement. So through this exercise, we've had a lot of questions from CEOs and CFOs saying, okay, you're telling us this, we agree with how you've assessed it, but now how do we move forward? How do we improve that performance? So really, again, just iterating the motivations of why we did this as an organizer. Sorry, there's a noise. I'm just going to stop the noise. So the reasons that we did this was really geographic location. So we had a number of entities say, look, we're operating in our country. Can you help us understand how others in other markets are facing similar issues? Are we addressing them correctly? Can we learn from others? A lack of access to relevant information. So how can we bring together this data to allow people to compare themselves? And please remember, the data comes in, it's completely anonymized, but then people are able to use the Tableau database to then assess themselves and look at regional differences, etc., etc. We also recognize that, people have tried this in localized areas, but there's been a bit of a reluctance to share sensitive data. And then also lack of understanding around what can I do from a operational performance, a clinical performance improvement. So again, lots of questions coming out and really good insights from many of the entities that participate. And what we're finding is that everybody's facing similar issues, but they're operating them from a slightly different level of maturity. Resource planning and optimization comes up a lot. So staffing and asset utilization. And then, as I said here, it's that financial, that operational, that clinical sort of performance improvement. So for us, it's to give a practical tool, which I believe we've done. We want to encourage the knowledge sharing, like this event today. We're also going to have separate events where we're going to specifically talk about specific entities and their performance improvement journey, encouraging innovation, promoting sort of quality and improvements, but then also, as I've alluded to, is identifying these common themes and potential bottlenecks that impact performance. We're able to now leverage, we're so rich in this data that we're able to leverage this data and share back these observations. And actually, I received an email earlier this week. We did the same feedback in South America, and somebody suggested, could we start using an AI tool to start looking at the data and pulling out more trends and helping us analyze even further. So the whole plan is to do this more and more. So let me just give you the overarching observations, then I'm going to drill down into some of the specifics. So there are wide variations in performance, and that would be expected. So what we're seeing, and this is through each iteration of the benchmarking, market nuances impact the way a hospital performs. Now that can be the maturity of the market in terms of payers. So some have heavy social health insurance, some have a heavier private health insurance or a dedicated private health insurance, whereas others are operating in a cash-driven market because there's no insurance penetration. Business model maturity definitely impacts performance, and we're going to come back to that. As does service type. And what we're noticing is some specialities drive certain traits within a hospital and performance, utilization of operating rooms, utilization of certain equipment. And what we're finding is if you don't have some of these things in place, it does impact performance. Access to healthcare professionals, I'm going to come back to because it is a big issue and a big challenge. And this financial protection, I've already alluded to that, but the ability to pay. And in very difficult circumstances in some markets, given the lack of insurance penetration or benefit caps or gaps with that penetration. So they all impact performance and they all impact asset utilization. And the findings coming out of this exercise sort of align with the observations my colleagues make when we make investments into the sector, that we're looking at many of these issues when we do our operational due diligence and understanding those market issues. There are regional variances in performance, but actually generally lower than we thought. So overall, on average, participating companies are performing similarly financially to international public listed. So what we also did with this, we collected the data from the 50 entities, but we also access publicly available databases to actually then enrich and further do comparisons. One common observation coming through is the lack of day surgery in many of the markets that we operate in. So it's highly underdeveloped, and I'll come back and talk about that. Quality indicators are now established in some areas, but there are concerns still about some underreporting on that. But we have seen strong evidence that the benchmarking program is increasing the levels of quality measurement. So if we went back to entities that participated in the pilot, and we now look at those same entities now, the richness of quality has gone up. So we see a direct correlation of increased quality sort of focus. Measurement of maternity, and this was a pilot, so I want to emphasize that the maternity was a pilot, but it does suggest that there is some underreporting taking place on some clinical areas. We piloted this to learn. So the next iteration, and we are welcome to ideas on what we can include in the next iteration, will have an expanded focus. So I really want to just summarize what the benchmarking is before I go into some of the specifics. So there's a financial component to it, which we're really looking at cost structure, revenue profile, profitability indicators, and pricing indicators as well. There's then an operational component, which is really, for example, the bed utilization, key asset utilization, human resources, and sort of the payer mix as well, because they're all interlinked and intertwined. We then have the quality section where we're really drilling down and understanding, mortality, hospital-acquired infection, adverse reporting. And then, as I said, we started through this pilot on sort of the clinical outcomes. The day cases has been there for a couple of iterations, and we've now added the maternity. And for those of you that have access to the full report, and if you don't, please reach out and we'll show you how to get the full report. You'll find that there's an annexure in that full report that gives you all 148 indicators. So let's start having a look at what the activity data is actually telling us. So we're saying utilization of key healthcare facilities does vary, as would be expected, based on maturity, market, etc., etc. And we're seeing the increased productivity. And what we're saying is, if by just a little bit of an improvement, that many facilities could actually serve more patients with the same infrastructure. So it's really understanding what infrastructure do I have, what services am I providing, how better or more efficient or more organized or more process aligned can I be to drive that volume through. And you can see there's some interesting variations. So the very wide variations are sort of core, what I would call high cost hospital facilities. And then, excuse me, I'm just going to move this. And then some variations are explained on this business maturity. So what we're definitely finding is that the first 5 years, and there is a slide coming on this, that the performance is still in ramp up. And from an investment perspective, from an IFC perspective, we often see, our own investments, and this sort of correlates with what we're seeing, that a greenfield hospital takes 2 years to build and 5 years to get to that comfort zone from a sustainable financial performance. Excuse me, we often see business cases for brand new hospitals that say they're going to break even in year 1. I would go as far to say that's absolutely impossible. We've never seen it in 25, 30 years of investing. So we're very conscious that you've got to be very mindful that during a greenfield hospital, you need to manage that performance. And it's often in the 3rd year of operation that's going to break even, which has impacts on your working capital, on your liquidity, which means you have to have a performance mindset right from the outset. And also a lesson learned, and this came out of the COVID period, because as you all know, healthcare facilities struggled during the COVID period. Some benefited, but many struggled. And what we realized was that those entities that had a clear line of sight to how they're managing their performance, how they're managing their costs, were able to get themselves through that difficult period more easily than entities that might have been more orientated towards that revenue. So quite often we see a heavy focus on revenue growth, but it's not the only thing you should be looking at. From a performance perspective, it's that cost, it's the performance oversight, it's clinical management. Those entities that were able to do that seem to cope better with the turmoil that was caused by COVID. Wide variations in high cost equipment. And again, it's really down to access to the equipment, maintenance and spares. If you're going to buy high-end equipment in a market where there isn't really that equipment, make sure that your supplier or the distributor can provide you with timely service and access to parts. So that is a key challenge that we see in many markets. The other common thing that came out as we talked these results through with each of the 50 entities was, do you have the right specializations in place to help utilize that equipment? And quite often that's not always the case. Or do you have the ability to drive referrals in to utilize your equipment? That's not always in place. So again, there's certain building blocks that need to be put in place to help utilize that equipment. And if you're not utilizing the equipment correctly, you're carrying heavy costs. So then how do you manage that effectively? And you can see that variation coming through there. This comes back to my earlier point. years in operation. So we have 5 years, over 5 years, and you can see here just on some of the figures that, you know, under 5 years the hospital is still ramping up. It's still putting in place the right specialities, or it started with speciality A, B, and C, but it now needs to migrate to X, Y, and Z to fulfill the whole sort of component of services that are required. So business longevity is absolutely a key determinant of the performance. And as I said at the beginning, it's observation during these conversations, but an observation just generally from an IFC investing perspective, it's really important to put the fundamentals in place from day one, so you could actively manage that performance across the whole spectrum of sort of services, finance, operation, clinical, etc., etc. And then I've made a comment at the bottom already about the Greenfield Hospital. So this is an interesting one, the sort of the regional variances, and we weren't sure what to expect on this, but really what it's saying is perhaps the facilities in the Asia region and the Middle East region show the highest levels of productivity. The ones that are really focused on sort of how do I get the maximum productivity out of my facility, the maximum utilization. Hospitals in sub-Saharan Africa appear to have generally lower productivity levels, and I think that's really reflects the challenges of the market and the general maturity of those markets, particularly regarding sort of high cost assets as well. And it becomes a very difficult balancing act. And Dr. Austin's part of the panel. I'm sure he'll give us some feedback of how you plan a private hospital and get productivity right in difficult environments. We did observe greater variations within regions, and particularly, let's say, on the Africa region, that no one country is equal. Each has their different nuances. So if I was to compare Nigeria with Kenya, it has challenges, but it does have a higher level of penetration from both social health insurance, on which the private sector is working with, and also private health insurance. Whereas Nigeria, as many of you will know, the out-of-pocket spend in Nigeria is, I think, when I last looked, was close to 70% public and private, which it's a completely different market arrangement. So all of that comes into the way these assets are utilized and the way the productivity works, and then as a result impacts on financial performance. This is an interesting one, liquidity. So you'll see here that we have the international publicly listed healthcare companies, or you'll see the benchmarking average. So yep, it's close, but definitely in the markets that participated in this, that financial profitability and returns achieved by the members there are some liquidity issues, and that does vary per region as well, particularly around the receivable days. And I really want to flag this as, again, from an investment perspective, working capital, access to cash, liquidity, they really impact businesses quickly. Another thing that we've also learned is getting the balance right. And this will be, if the CFO's on the line, you'll know what I'm talking about, is getting the balance right between how much debt can I take as I grow my business. And if there are certain nuances in the market, if I don't have my productivity right, if I'm not addressing some efficiency issues, carrying too much debt can actually hamper your business in the first stages of growth and development. So it's all about getting that balance right. This one's an interesting one. So I don't think the statistic is on here, or maybe I've missed it, but I think 47% of the participants are working with social health insurance. So one, it confirms that the private sector can work with social health insurance. It shows that the private sector is interested in working with social health insurance, but there is a little flag that needs to be raised that receivable days from social health insurance tend to be longer. So if you are working with social health insurance, processing claims can take a little bit longer than private health insurance, and of course, out of pocket, in theory, should be the quicker payment method. So you've got to plan and understand your market dynamic, and that does impact on receivables, which can impact on liquidity. Now, staff turnover. This varies per region, but there's an underlying trend that staff turnover is a problem. So many African countries currently have the problem from multiple perspectives. One, brain drain. So there's a lot of healthcare professionals, understandably, are going out of the country because they see more opportunities, in some of the Western markets. We're also seeing, as the healthcare sector grows and matures, there's more public sector provision, more private sector provision. But because training of healthcare professionals has been so low, there's not enough in the market. So there's local churn happening as well, and particularly around scarce skills, specialist nurses, ICU nurses, operating room nurses. So again, this does prove quite problematic and needs to be managed. We have seen some high levels of retention, and that high level of retention seems to be coming from groups that are able to establish career progression. So I may work in hospital A within that group today, but there's a career opportunity for me to work in their next facility or in another city or another town down the line. So I'm retained within the group. And linked to that is training and development as well. Day surgery, yeah, this is an interesting one. So day surgery is across the board is underdeveloped. And the orange bar here is taken from the UK. So this was UK data in the orange bar. And basically you'll see that the benchmarking club falls beneath that. The main reasons seem to be specialists with the right knowledge to do day surgery may not be in place. They also may feel they're not confident enough in discharging the patient on day one because they don't know the circumstances of that patient at home, and it may not be as coordinated as maybe the UK is. Payers sometimes don't understand how to process claims for day surgery. They expect you to be in for one night and it doesn't show up in the system, so it causes confusion. Patients don't necessarily understand as well. So there's many factors around day surgery, but what we have seen is where day surgery is used well, that it drives volume. And so we encourage you to consider and look at day surgery if you have the right processes in place from a clinical, from a quality, etc. It does support volume growth, and it actually, and the clinicians on the call will know that good day surgery done correctly actually can improve outcomes and gives the patient better care. Quality measurement, so it has been established in some areas. It's a bit mixed, as I said, and you can see here from the sort of those hospitals reporting certain things. So ICU deaths, for example, is at 88%, so it's been accurately reported. But then falls in the outpatient department is mixed. So again, the data has been collected, but what we're seeing is there is the potential to manage that data better, and also maybe have that focus on certain of those quality indicators just to make sure there's a comprehensive focus on quality. Formal accreditation appears to impact the levels of completion of quality matrices. Apologies here, I noticed that this chart has gone wrong since I did it the other day, so I don't know what happened. But basically what you're saying, what we're showing here is the sort of, if you have formal accreditation, it does benefit quality reporting. So again, some accreditation is very expensive to achieve, but there's lots of different international accreditations out there. But healthcare accreditation does help quality, which does help performance, does focus on the patient, does help with the coordination of care. And as I said right at the beginning, repeat participants in this benchmarking club, what we're seeing here is across these 17 indicators, they have improved their performance. So the completion rates have gone up. So there's been more focus on quality as well. And I'm sure this will be a panel discussion that Rihanna's going to ask a question on this, because I found this really fascinating and it made us really pleased to see this indicator coming through. There's no evidence in the data that says high productivity reduces quality. And in fact, what we have seen in some hospitals, because they know that they've got such high productivity and throughput that they have to really understand every single process. So it's that waiting time, it's that getting that patient into the operating room. It's all of those interlinked processes. And so what we've seen in high productivity institutions, there's a big focus on process. So everybody understands my role in treating the patient, managing the admin of the patient, coordinating the patient. So this process focus definitely supports better productivity, and it definitely supports better management and oversight and performance. And I'll give one example, and I'm going to finish shortly. What we've seen in very young healthcare businesses, those businesses that are able to scale quickly, they've been set up on the premise of process. What are the financial processes? What are the operational processes? What are my clinical processes? What are my patient coordination processes? By having a look at that right from the outset, it drives productivity, it helps performance, and it helps create value. As I said, maternity is still slightly underdeveloped, and I know Jana's going to be asking a question on this as we go through. And I think it's just general reporting and the general sophistication of reporting as well. And often what we've seen is that clinical reporting is done here, operational reporting is here, and often there's a like mismatch. The systems don't always align. So we really encourage to really look at how systems can be integrated. And also a lot of payers now are wanting to work with providers and looking at that data and managing certain patient groupings. Lowest quartiles and lowest reported values for maternity outcomes. So here is another good slide, sort of, highlighting, how the unexpected complications in new term babies, and then the other, you'll see here some gaps in the data. So again, some interesting statistics coming out of the data here on maternity outcomes. We're going to repeat it next year, and we'll probably expand the focus on data as well. So the last slide. So what are we hearing? So as we've given this feedback, and as I've said, we have 50 conversations on the back of this benchmarking with the entities that have participated. And we're saying, okay, what is it we could do differently? Where else may you want help, or how can we help facilitate conversations between different entities in the group? Operating theatre workflow management and improving operating theatre efficiency was a common area where people were asking for sort of how can we do better scheduling, how can we get patient flow, how can we maximize the sort of the utilization. Specialist doctor engagement models. So you probably heard me as I've gone through saying if you don't have the right specialities in place, it impacts the way your hospital performs. And not all doctors are operating full time because of in many markets, it's the third party doctor operating model. They come from the public sector, they work across the private sector. So it's also, we've been asked, well, what models are out there, effectively, ethically aligned models are out there to engage and retain specialists. More questions around quality improvement, what to measure and how to measure. HR planning was a common theme. So how to strengthen workforce planning, how to align staffing levels, and how to get that skill mix right when there's a shortage in some markets, for example, of those specialist skills. And then the final one is how to retain on healthcare workers. So that's it for me. I've thrown a lot of information. If you want clarification, please put a question in the Q&A, and I'm sure Jana's going to ask questions now that can also help clarify. But again, I'd just like to say thank you for participating and also for listening today. Jana, back to you. Thank you.
Thank you, Charles. When I always look at our data, I found it every time fascinating. So I'm really glad that we are doing this project. And we will discuss the results and most importantly, discuss with our participants how they applied it. And also I would like to the panel members to share their reflections down the road on how they think even the participants of this webinar who have not part of the benchmarking, how they can start using the data that would be released through that has been presented today and then would be posted online, how they can use it in their daily practices. So start thinking about it. So once again, we have Dr. Austin Okogun, who is CEO of Lilly Hospitals in Nigeria, and we have Dr. Sandra Morovic, who is Chief Medical Officer of Arsano Medical in Croatia. Two very different contexts. Both participants participated in IFC Healthcare Benchmarking, and I actually wanted to ask them first what got you interested into this project? Why you decided to participate? Sandra, do you want to start perhaps?
Sure. Hi. Hello, everyone. So good morning or good afternoon. And thank you very much for the opportunity to share actually our experience with IFC. So I have to be honest that in the first round 2 years ago, we got engaged. Actually, it was a referral by a business partner. So I wasn't aware myself of the project before that. And honestly, in the beginning, the first round was the submission of data was a little bit chaotic for us because we were just a newly formed medical group, with many directors of certain hospitals and clinics and so on. But once we managed to submit everything, it was actually, maybe I should start by saying that when we got the results, I received some reassurance from you that what is happening to us is actually quite normal with the differences and with the averages and with the data that you showed for all participants. And then actually we started thinking about it, and it helped me a great deal in the future because I actually accepted your way of reporting. So it helped me a lot to set up a follow-up method for myself and for my group. We have 9 institutions in the medical group, but only we have 2 hospitals, and those are the ones that participated in the benchmarking program. So after that, we got a lot of data from you. Like we have a different structure from the two hospitals in the same group functioning completely different. And a surprise was in this year's report. For example, the nursing staff was that we were maybe understaffed, which maybe we would not have in the daily work because of the fluctuations of the periodical, the way the business is working. So you asked us how we improved our quality system after the first round. We actually introduced a few things, of which one was the complete patient satisfaction survey that we do for all our patients that enter the group. And it's the patient satisfaction and the patient experience and the NPS score, which is taken very seriously now. Every complaint that comes in, there's a report, there's a process, and each one is dealt with separately. Also, the inpatient and the day surgery. This was very nice to see how other hospitals stood in that area. So we're also trying to work on the day surgery, and it is a trend, but I think that many hospitals participating have the same problem that might be a little bit also cultural, like you were saying, Charles. People are not ready to come in and leave the hospital on the same day. They like to stay overnight. So it's something that we're trying to do, but you can't push it too soon. I think it has to be a culture for that. We have much better utilization of our MRIs right now. That's not seen in the report because the other MRIs are in other institutions that were not in the project, but we use the same scheme for improvement in all of in all the institutions of the group. So what I would say that you gave me is a great communication tool to help me translate medicine to management, which is kind of my job to ensure that the doctors and nurses and the medical staff has everything they need to be able to perform at their best. But I also have to present that upward in case of investments and decision making of that type. So this was really it was a great experience for me. I wasn't even aware of it at the moment that we entered the benchmarking program. It was only afterwards when we received the results and when I was able to compare it that I actually saw the benefits that you were that we were given, let's say.
Thank you, Sandra. Thank you for sharing your experience with the project. Dr. Austin, you have been with us from the initial conceptualization of this project. I actually recall when we consulted with you, when we even thought whether or not we shall go into this. So, and you participated in the pilot and 2 subsequent rounds. So how did it work out for you? So, and how are you using it internally for tracking performance or for initiating some performance improvement work? And can you please share?
Yeah, thank you very much, Yana. I hope my voice is clear. I'm glad to be here. Truly, I've been with IFC on this journey from the beginning, and it's always been fun being here. I know that when I was asked the first time if I was interested in this, I said, I didn't have to think about it. I said yes immediately because I knew that data is something we need if we really want to improve. I mean, particularly benchmarking across, geographies. Before then, we've been trying to track some data even internally, and we kind of could monitor our improvements in certain parameters. But it doesn't feel as good if you know how other players in the industry are doing compared to yourself, because looking internally alone at your vertical data sometimes can be very deceptive. It may give you a feeling that you're doing well, and in reality, you may be doing very badly. And we thought that it was important that we had cross-border kind of data to benchmark against, and the IFC platform actually gave that. Because the major challenge with getting data locally, and I'm sure it happens everywhere, is that not many hospitals are willing to share their data. So you wouldn't be able to even get any peers to compare your data to, and that puts you in the blind. So having the kind of platform of IFC data, this benchmarking, is good because it anonymize participants, and so it helps you to have confidence in it. So we've participated in all of them. One of the things that have helped us with a lot is that the first time we participated in this program in 2022, we didn't provide much of what was expected of data to the IFC, and seeing the gap, in our level of data reporting, you could see that the difference between what we're able to put forth in 2022 and 2024 is quite wide. From offering like 67% to about 88%. So it has helped our data maturity, our key maturity significantly. And the data has helped us a lot to understand, where we stand, relative to other players in the market, even across the globe. And in areas where we had thought that we're doing very badly, it gave us some confidence that we're doing well and we'll keep continuing to improve. In areas where we thought that we did, where we realized that, we could have done a lot better. And that for me is very important. At the moment, what has happened that we have moved away from just collecting data to actually analyzing it deeply, because we now have a unit, a department within the hospital that attends to data analytics units, where we have people who constantly analyze our data and do the comparison across our various locations internally, and able to do some global benchmarking with available data globally. And that is actually helping our reporting internally, because when we get our quarterly reports, we're able to see where we stand, in terms of our historical, where we're coming from on the trend analysis, and how we compare to some other available data globally. So this, for me, is very helpful, both from a financial standpoint, the operational, and all the other parameters that we use, to gather data to benchmark. You and I know that naturally, benchmarking is a natural human behavior. Because sometimes in business, we don't do much of it. I mean, you could imagine that if you're dressed for a party, when you go to the party, you also want to observe and look and be sure that you're well dressed compared to others. That's for me, it's actually benchmarking. You're always comparing. It's a habit and behavior we need to bring to our businesses, where we gather data, to look at our trends, compare year on year, year to date, but more importantly, compare ourselves to other players, both in our local markets and markets beyond where we are. And this whole benchmarking has revealed a lot to us. Has shown areas where we need to focus on, significantly to see how we can up our business. It has also shown that in some areas where we thought we were doing badly, we're not the only ones in it, and there's reason for all of us to come together to work. But I think that overall, as IFC continues to do this, we have more insights, from what we do, because the quality of data to be provided, the use of the data, the comparison of data within, geographies, maybe details that will help us over time to continue to improve on our journey. Thank you.
Thank you. So I'm hearing it's first and foremost, it's actually helped you strengthen your own data analytics and interaction with both with staff and management, and also clear it so that you get more transparency about the operations within your system. But then going from data to improvement, and perhaps I can ask Charles to comment on it. So, Charles, what do you see as a good use of benchmarking data by healthcare facilities, and what is not? And how you can, because it's multifaceted in our benchmarking, but how it can be used for some either performance improvement or better investment planning. Can you share your thoughts on this?
Yes, sure. I mean, I think the first thing that I'll say is you need to understand why you're collecting data and what you're going to use it for. And I think sometimes a fundamental mistake that is made, that data is collected for the sake of collecting data, and it's not utilized or it becomes overwhelming. So that's just a general observation I would like to say. I think for me, I think Dr. Austin sort of touched on this as well. It's the data, and a focus on performance helps you to understand your business. It helps you understand what you're doing well, but it can also help focus where you need to make improvements. But then when you make those improvements, you need to then drill down and saying, what is it that I need to make in those improvements? And I might not be making sense, but often, if you're looking at your operating room efficiency, okay, it's not just how those operating rooms function. It's, am I getting the right patients coming into those operating rooms? Do I have the right specializations within my hospital? If you get my drift. So often in a hospital, you might be looking at one issue, but there's multiple other factors that are influencing. So I think that's the important thing with the data utilization, is understanding the problem that you're looking at, but then understanding what are the multiple factors within your facility. So another good example on operating rooms, some hospitals don't have the right operating room nurses in place, or there's a lack of ice coming out of the operating room. Patients need to go through to the ICU. There may not be the right staffing in place to operate the ICUs, which means you're restricted in your ICU provision, which may mean you're then restricted in what you can do in your operating room. So there's a lot of interlinkages in a hospital, and that comes back to my comment about process. So it's having the data, it's understanding what you want to use with that data and what performance you want to make, but then it's also linking that back to the processes within that hospital and how everything sort of links together. So I think that's the sort of a common sort of observation that I'd make. Thank you, Yana. Sorry.
And for investment planning, I mean, how, perhaps you can comment on this as well. Yeah, because the charts, and will just comment for the participants. You're actually getting through in this presentation a little bit of the preview of the distribution that we collected on the utilization of core assets, the 25th percentile, the median, and the 75th percentile. So how would you recommend that people are using this for investment planning?
Yeah, it's a really good question. And I think a common mistake made, and this is me giving you just an external insight, is I want to build a state of the art hospital. So I want all of the bells in bells and whistles. Yes, that's commendable and fully understood. But does your market support that?
Yeah.
So that's a key question, and we see a lot of mistakes made in a lot of markets because actually the market has a massive demand supply gap. So the automatic assumption is people are going to walk through the door. So that's not always the case. And so you really fundamentally need to understand your market and the services that are required. And from an investment perspective, what are the core services I need to start getting that volume? And then what can I then add further down the line? So it comes back to my point about that process and understanding certain key indicators, which will then direct you to what you need to invest in. I'm making it sound really easy. It's not, it's complicated. But understanding your data, understanding those performance nuances definitely seem to benefit hospitals where they've got that focus, because it takes them on a journey of what to invest in. And then from a financial perspective, in theory, and I'm saying in theory, it should make it easy to manage on a more financial perspective because you're not carrying a lot of debt. You add your debt when your hospital is performing to certain levels of maturity. So I can't emphasize enough the importance of your market understanding, your performance understanding, and having the data to drill down to make those investment decisions. And I think that's something that Sandra and Dr. Austin has been doing this in his model in Nigeria, given the challenges of that specific market. Thank you.
Okay, Sandra, please. I guess you want to elaborate on some of this use of it. I see your hand, so please.
Yeah, actually, I had a comment, but from earlier still, it's when we talk about all this, there's I still have the feeling that quality gets the wrong perception. Because when we mention measuring something to colleagues and to people that, now you have to note every fall, they still perceive it as a control mechanism, not as something that is actually protecting them and maybe rewarding in the end. So I still see, I don't know if other people have this same problem that when I tell them now we will do a follow-up on this and that, it's kind of, they never want to note a fall or infection or something, not understanding that it's not a punishment issue. It's just prevention and working on improvements. So I still think that there is a gap that we need to work on. That was just my comment. I will.
Yes, and very true. Very true, very true. So and we are doing a lot of work on quality and quality measurement specifically, and even benchmarking shows that for half of they do measure it, but for half of the participants, the values are zero or close to zero.
Yes,
so
we're
an
also
infections rate cannot
be
cannot be zero. Yeah, we know it, and basically people are not being transparent with themselves. Yeah, so that, and actually I want to discuss this question deeper with Dr. Austin, who I know is a great proponent of quality, patient safety in his hospital, but also broader in Nigeria. So Dr. Austin, how do you think it's possible to shift this mindset? So from of what Sandra has been talking, we are measuring or measure falls or even near misses on falls and so on with the staff and broader community. How it's possible to accomplish this?
Sorry, I got cut off by internet. I don't know. I may have missed your question.
Okay, I will repeat. Sandra has been talking that on quality, it's quite difficult to get staff on board on reporting things like falls and other things. They see it as a don't understanding why it's important and don't report it properly. And it's confirmed by the benchmarking data. So many participants have, yes, it's formally included. They did submitted the data, but the data was very close to zero. And we believe that it's not a good thing. I think we suspect that it remains underwater. So, and you are a great proponent of quality and patient safety in Lilly hospitals, but also broader in Nigeria. What do you think should happen from leaders' side to make sure that it's actually perceived that it's important for us to have full transparency on this, on incidents, near misses, falls, medication errors, and all other things?
Yes, thank you very much. I think that's the big problem I think I have observed myself in my experience. And we do understand that there are many reasons why this are happening. First and foremost, I want to ask the leaders how to be patient to allow that transition, the cultural change to take place. Because the end result, the end culture that you want to achieve is a situation where everybody freely shares data and uses data to make decisions every day. And that's not going to happen overnight. Now, we must realize that there's a conflict usually between our traditional culture and our desired organizational culture. Many of us come from traditions where have been exposed to some cultures traditionally where there's a lot of blame, when things go wrong, and people bring this kind of traditional culture, perspective to the workplace, and it does affect how much your organizational culture evolves to where it wants to be. So it takes time to get, people to have the confidence, in the kind of system you want to put in place. It takes time for you as a leader to reinforce so everybody's understanding that we're not trying to build a blame culture, and that the reason for looking for data is not to blame anybody, it's to help the system to be better, not just for the patient, but also for the workers. So in our environment, what we do is that we do periodic, monthly, quarterly, database business performance analysis, and we don't seem to blame anyone. So when people observe and see that the data are actually used for good, not for blame, then people begin to change their behaviors towards not only reporting data, but also use them for the work that they do. So if you look at our own reports, for example, between 2022 and 2024, we had a quite significant improvement in data reporting. That's because of this kind of emphasis on the fact that data is needed for improvement, not for blame. And that improvement has to be clear to everybody. What are you improving? And when you improve, how does it benefit them? How does it benefit the system? How does it benefit the patients? When that is clear to everybody, people participate in that process. I think we need to be patient about it. I think we need to keep reinforcing that communication, and we need to walk our talk, and over time, people will buy in to the point that we want. Thank you.
Thank you so much. And what's this important nuance? And I see a comment about the just culture workflow and being no blame, to be a fair blame, and how to make sure that staff, it's a fair blame, it cannot tolerate negligence, but at the same time, staff are not afraid to put certain things out. Perhaps both you, Sandra, but also Charles, if you want to comment on this. How to achieve that?
Well, maybe some anonymous reporting, or also I heard that some people even gave rewards to those who reported like near misses and stuff like that, so that they were actually stimulating people to. Some can maybe make it like a game, or it's not a funny thing, but to make it less serious. Maybe it's just to get people to get the sensitivity to report. So I don't know, I'm also trying to think of something. So
but actually, in this respect, using on near misses and incidents, using the 75th percentile of those who report more as a rule of thumb in terms of like how many incidents there should be per bed. So these are the entities that seem to be more transparent with reporting, and like why there should be a reason to be doing better. Charles, I see your hand up. Please go ahead.
Yeah, it's a really good question, and the example I'm going to give comes from my before IFC, and we were doing work in South Africa, and it was with public sector hospitals, And one of the things that we noted was everybody was working in silos. So the clinicians, the nurses, the technicians, the management, the administrators, they weren't talking to one another. And what we noted over a period of, I might be getting it slightly wrong, 6 to 9 months, was we were trying to help them create an internal focus on how they could process and how they could perform and make performance improvement. And one way we did it was to set up teams that were integrated teams. And the multidisciplinary team, I know, is a clinical comment, but we basically expanded out to saying the problem that we're trying to look at and to change that cultural understanding requires doctors, nurses, technicians, administrators, finance people, procurement people, all looking at the same, looking at similar problems, and to understand that they all have a touch point in and around that problem. So I'm using a general example, and it actually worked, because then people, the clinician understood, why is the finance guy asking me these questions? Or why is the nurse asking me that question from a quality perspective? And so then everybody started to understand that they all had a role in the process. So I can't emphasize enough that on performance, on culture, on teamwork, it's creating this integrated approach. So that's just one example I can give you, but it absolutely genuinely worked. That then once people started understanding the role that they played, that it started to take away that blame culture as well, because there was an integration and an understanding. Thanks.
Yeah, and there is a follow-up question to Dr. Austin, and I will read it out because it's also on this topic. Other than the continuous emphasis that data is used for improvement and not blaming others, are there systems, mechanisms, or quality improvement projects that can encourage or improve reporting?
Yes. Well, in our hospital, for example, we encourage each team to carry out the quality improvement projects. They own it. They themselves understand what their ultimate, outcome should be like. And then so when they see shortfalls in their performance, they carry out quality QIP, quality improvement projects in order to close the gap. So when teams come together to own an improvement initiative around quality and data reporting and all. Beyond that, automation helps a lot as well. We've tried to use automation to close some gaps, because when some things, when the controls are strong enough to prevent you from doing the wrong thing and arriving at the wrong outcome, that also saves a lot of losses that would have come from that, and a lot of takes away all those issues that would have led to any blame whatsoever. So automation is another way that we can achieve that, because we use a lot of decision support systems that will help to help people who take decisions to make the right decisions and to prevent any harm from occurring. That also helps a lot. So it's a combination of what you do as a culture and what your system, also helps you to achieve.
Okay. Thank you so much. And I guess we'll shift gears a little bit. Questions are coming up, and I guess the question that was asked, I think Charles would be best positioned to start on it, and then we'll ask Sandra and Dr. Austin. The question is there a link between business longevity? Is it a function of time to develop market and capability? I guess it's on to the points of the performance, better performance of the below 5 years and after 5 years, or is it because at 5 years and beyond, you are simply looking at the survivals? In other words, do some or many hospitals fail early on, and what predicts the ones who succeed? So I guess obviously our data set only covers the survivors, but perhaps from your experience in terms of what do you see in terms of mortality rate in the first 5 years?
That's okay. I think we could do a whole session on that question. So yes. I'm just going to give you a very high level overview, and I'm more than happy to take that conversation offline. Look, I think I've already alluded to it. So I think where hospitals may struggle early on is ambition. And we reject many projects from an IFC perspective. And often the reason we reject those projects is we cannot align the size of the project with the market nuance. And so my preference with a hospital is to develop in phases. I know that makes it slightly harder from an infrastructure perspective, but you don't need to have a 300-bedded hospital on day one. And so a lot of hospitals often make the mistake early on. They carry too much debt in the first few years of operation where they're not going to break even. Now, as a CFO, if you're carrying all of that debt and you're not breaking even, it puts unnecessary pressure on the rest of the facility. So it's a very careful balancing act. So that where we see the hospitals that can grow appropriately, they have a clear understanding of what are the right specialities that I need to have in place that can drive the volume that I need. And then I can build off the back of that volume and start implementing other services. So again, that's sort of a common thread and a common understanding that we see. 5 years, yeah, I think we use the term 5 years because we know from an IFC perspective that, and again, I'll give you the analogy of a new greenfield hospital. So it's 2 years to build that facility. You then got 3 years where you're bedding everything down, getting everything to work. You're also ramping up, and that's in that 3rd year. So 5 years, 2 years, 3 years of operations. That's where you probably normally break even, is the 3rd year of operation. And then a further 2 years, to bed things down. And I wouldn't say after the 5th year it's a case of survival. It's really on the 5th year you're at that maturity level. You understand that business well, and you start evolving and developing and sort of and start moving forward. Again, I've made it sound really simple. Again, each country has its own nuance, and maybe Dr. Austin, would be good to get your views on this as well, because I know you've evolved your hospital group, you've built it in phases, and that's where performance and benchmarking can be advantageous. And again, using that data to really understand what's working, what's not working, and then to help inform where you make those decisions. And then when do you make that strategic decision to then suddenly expand, get more higher level equipment, and get the right specialties in place to drive that. So it's a balancing act continuously. So hopefully I've answered the question, Jana, but I'm sure Dr. Austin can also give some insights from his experience. Thanks.
Dr. Austin,
Yeah,
any comments?
Yes, I agree very much with Charles. Everything is nice to have, but you have to focus on the needs to have or need to do. Doing healthcare business is like any kind of trading activity. For me, I see like a trading business. You want to make profits. Who are you selling to? And what are the needs of the person you are selling to? What's your capacity to actually be able to serve those needs? One has to be realistic about what is out on the table and what is actually offering. So bringing in more than is needed is a huge problem. And as you evolve over the years, you get a lot of insight into the reality, which is different from your initial assumptions. And how do you respond to those, insights, that comes your way? Do you ignore them and hope that things are going to get better? Or you take quick decisions to shut down areas that are not doing very well from available data, and then come back to them later when you've survived? Or you want to keep hoping and then wishing that some miracle will happen and then your business will turn around. Such hopes actually lead to early death. So I believe that it's like any trading business, is buying and selling, you try to make profits. You must be aware of your costs, your cost profile. You must also be aware of who you are serving, what your capability is to even pay for your services. And if you don't balance those together, you may run into trouble. So at 5 years, I believe that most hospitals would have known enough, leaders would have known enough of where their strengths are, where their weaknesses are, where the opportunities are in the markets, and what may be very threatening that may get them out of business. So that understanding will help you to go to create a kind of business model that keeps you surviving in the markets until you begin to achieve the kind of milestones you want to achieve. So I think that 5 years is actually a good time for everyone to go to have a sit down and have a playbook that is more realistic compared to the assumptions to make at the beginning of starting the business. Thank you.
Yeah. Sandra, anything to add on this? If you would like or not.
Yeah, I just have to say that I agree with both speakers, and I think that Charles summed it up very nicely. We went through a similar process for a new hospital, but actually decided to postpone it for all those reasons, because one thing is in theory, which is very nice, and then you have to translate it to practice, and then you have to see how many doctors you have to find. You need them full time, because when you talk to people, they're all ready to change from maybe public hospitals to private sector and so on. But then once you reach them and say, okay, now is the time for you to transfer or to start working here, then it's a process of another 3 to 6 months, which usually becomes a year or something of decision making. So I think these things have to be very carefully thought out and be very realistic when you decide to expand anything. One thing is the investment itself, but the other thing is also this part, the staff that you need, especially maybe in smaller countries like we are. You don't have so many specialists to choose from, and there's competition, of course, always growing. So yeah, it's very difficult, and it's a very delicate area with many factors to be taken into account, not just the money and the space and the people. So yeah, that's our experience as well.
Yeah. Thank you. It's actually, oh, Charles, I see your hand. Yeah. So please
Yeah,
go
no,
ahead,
no,
and then I would like to change
Yeah.
our topic to something else.
Yeah, Sandra just prompted another observation that we've made, and we sometimes see this in the way hospitals looking at their sort of financial projections, and sometimes they rightly build up their business model by looking at what services am I going to provide. But sometimes when we drill down into those models from an investment perspective, and I think it links to some of the findings we've seen in the benchmarking, that I'm going to run service A, okay? And I'm going to run service A full time. That when we look at it, we're then saying, well, hang on a minute. We know that in that market, there's not enough doctors in the market to provide that service, and your doctors are part-time. So how are you modeling that you're going to have 100% utilization for that particular service? So quite often there's not enough data analysis and performance understanding up front, which then immediately impacts the hospital, because they've set them a bar up here when automatically the market isn't able to sustain it. So again, I just wanted to emphasize that it's critical to understand the dynamic, understand the people side of it, and just understand realistically what can be achieved. Thanks.
Okay. So thanks a lot. I would like to change gears a little bit. And we piloted benchmarking on clinical maternity outcomes in this round. And I guess everyone in healthcare appreciate that benchmarking clinical outcomes is super complicated. And perhaps maternity was one of the areas where it's slightly, and I would name slightly, like a little bit more straightforward, but even there. So basically what we saw, and Charles alluded to it, it's first data, 2/3 of the companies roughly weren't able to provide the data. And secondly, yes, we have got the distribution on many things. Such there was a chart on unexpected complications in the newborns, and there the distribution was from nearly zero as the best practice. I think 2 to 3% as a top performing quintile, and then the worst performers were at 22 or 23%. So basically every fifth child, yeah, which is a lot, yeah. So I guess, and ultimately, healthcare healthcare service providers about high quality healthcare without unexpected complications, ideally. So my question to you, what do you think is behind this somewhat lower level of data submission and how it's possible to improve it? It's first question. And second question, because we would release this data of top performers, best record, and top quintile. And if a facility is above it, yeah, so performing, like, how would you recommend that they go about and initiate a performance improvement project in this area? Any views on that?
Well, if I may take, the step to answer first, I think the place to start from is to start asking for the data. I mean, your first round, you didn't ask for maternity data. Possibly no one thought it was as important, to also keep some of those data. And when you ask the second time, it looked like nobody had them available, to share within the time frame for submission. So I think asking for the data is one way to begin to, help hospitals like ours and the rest who participated in the benchmarking activity to bring together solid data because they may then be useful for benchmarking. And then once that is done, I think we begin to, because there's so much data to collect usually. In every business, there's a lot of data that can be made available, that are available. But the reality is that what is most useful for you, for whatever purpose that you want to use them for. And I think that brings it to fore that maternity data, as important as other data you've been asking for, will be one way to begin to change behaviors towards gathering and sharing of data. Thank you.
Okay. Thank you, Dr. Austin. Sandra, any views on this specific thing as a chief medical officer?
Yeah, I think it all comes down to communication again. A lot of work with the staff to understand the process and the reason for it. I think it's regardless of the area, whether it's maternity or something else, because my experience really is that people don't really understand why we are doing this. And usually it's always lack of time and somebody is missing. So I'm also thinking of introducing another form of informing the staff and regular meetings and encouragement to improve and to note. Because in the beginning, they always think it's just an extra work, like we're piling the people up with work. But in the end, once they go through the process, then they see also the benefits. So it's like Doctor said, it's a process and it's a lot of hard work. And I think that in the end, we do see a change.
Okay.
Yeah, thanks.
Thank you.
Sorry, if I may
yes,
add,
please. Yes,
I think
yes, please.
data is becoming very important. Maybe important to have a data officer in-house whose responsibility is to gather all this data, across, the hospital and make them available to both internal leaders and also to IFC or anybody that so requires the data. So having a point where you can appoint a particular person who's in charge of that will be one way, to be able to close that gap.
Okay. Yeah. Thank you. That's valuable. And coming back, we regularly do dedicated webinars or virtual workshops on issues related to quality measurement. We discussed a little bit on incident management and so on. That would be, I think we have done one a few years ago, but definitely would go into this area. But maternity outcomes and overall improving clinical governance and tracking for clinical outcomes. It's quite an important area that not too many facilities do. So that please watch the space, and we'll try to facilitate more peer exchange on this. I see we are 6 minutes to go to the closure. Perhaps I would ask each three of you to comment. How would you recommend facilities who are thinking and who got excited about this benchmarking? Because the next round would be in 2027. Yeah, but there is a readiness. And Sandra, you've mentioned that the first time it was a little bit difficult for you and a little bit stressful. But how would you recommend participants who are thinking, I'm interested for the next round, what they shall do now to participate in the next round? I guess that would be yes. If anything, what do you think? Yeah. What would you wish someone said? Hey, Sandra, you better do it now, or early warning. Yeah. So
maybe when it's colleagues that I talk to, I try to explain to them that it's actually for their protection, for protection of them personally and the doctors and the institution. And everybody else, it's a really great follow-up tool, and you really gave me things to follow up. So you gave me a good start for me, because the first time around, I was also new at the position. I was new with all these institutions. And okay, so you were really a great help, and thank you for that, because you gave me a starting point. And then it's easy to build on with your own ideas when you have something, when you have a core to build upon. So I would go for quality, for people to understand that it's really for their own good protection and better organization. And everything is easier once you're organized. So, of course, I could put it into many more words for them.
Yeah, thank you. Dr. Austin?
Yeah, for me, if you really want to improve, then you have to submit your data for benchmarking. Otherwise, using data for vertical benchmarking alone can become very deceptive. Doing cross-border horizontal benchmarking says a lot as to whether you're improving or not, and what you could do to improve, and how others are solving their problems, that you also want to solve. So any company, any hospital that's really committed to improvements, that committed to growth, we need to join this benchmarking activity. And you start small. You don't have to have all the data from day one. You submit what you have available to you. And over time, you can expand the scope of what you're able to gather internally in terms of data. And submit. You can do the benchmarking with what you have able to submit and learn from what is said to you. So there's no tools on both status where you are, and you always grow on it as we evolve. And the more data we have, the better we'll get. So I encourage everyone to actually, be part of this and just be able to get more insight on how they can take data-driven decisions, to improve their businesses. Thank you.
Yeah. Charles, I hope your sound is okay now. Any last kind of pieces of words for you for forthcoming potential participants in the next benchmarking round, and also how they can use what would be distributed as our open report, but also how they can get prepared for participating in the next round?
Yeah, sure. And hopefully you can hear me okay, Jan. I've had to change I've had to swap devices because I lost all sound. So for about 5 minutes, I've lost it all. Yeah, look, I think I would encourage people to participate. Two, what we have seen is a maturity of participants. So maybe the first time you participate, there may be gaps in the information that you supply, and that's perfectly okay, because basically, you can look at how you can make those improvements. So I think that's important to understand. I also think if you are considering it, you can reach out early to us, and that's maybe something, Jana, we can talk about for the next iteration. Is saying, we can help you prepare. So we can basically saying, look, these are the core fundamentals that you sort of need to have in place. And one thing that we've discussed, we've also noticed that sometimes it depends on who's in charge at the hospital in providing the data may shape the richness of the data. So sometimes if it's the finance team that's doing it, the quality team might not be giving all of the input, or if it's the quality team doing it, there may be some gaps on the financial operations. So a key thing in terms of preparedness is a small little team to make sure you're pulling data from all of the right places. So yeah, and I think I just encourage people to read the report, sort of look at the sort of analysis that's coming out. And also, I think we're more than happy from an IFC perspective if people have questions or they have specific issues, even though the next benchmarking is in 2027, please feel free to reach out to the team. We're very happy to, have conversations around performance improvement and what we're seeing and what we're learning. And we can do that in advance of the next benchmarking as well. And I think my final point is, from this exercise today and the sort of early iterations and other knowledge events that we're working on, we want to create this community. And we want this community to share and discuss. And again, I would encourage you all just to participate as we go forward in this, because there is richness in the data, there is relevance in the data, and it comes back to what I think I said at the beginning, that everybody is dealing with the same issues. It's just different levels of maturity. So you may be dealing with an issue today that somebody has already dealt with and already may have a potential to solution to help you address it. And that's why we want to create this sort of knowledge and community around performance improvement. So thank you very much, Jana.
Yep, thank you. So time flies. So we are closing. So we learned today that benchmarking in healthcare actually, first and foremost, it helps to improve visibility inside operations of the facility, but also compared to others. Data is useful for discussing and debating scenarios for investment planning, but also discussing and debating internally whether or not certain areas can be performance and then can be do better. So it's a tool to question yourself, first and foremost. So I actually would like to use this opportunity to talk about other IFC, other initiative where IFC hosts secretariat and on which we would be actively promoting another tool this year. And the initiative is Ethical Principles in Healthcare. We are about to finalize the self-assessment tool on level of implementation of the ethical principles. The link to the initiative is in the chat. If you are, I know that actually many of the participants are signatories already, but I would encourage, if you are not, please sign up, because ethical behavior and how to manage it correctly and how to manage ethical dilemmas in healthcare is another thing in which issues are very much similar, and it takes really borrow some solutions from other facilities may be a good idea. So please follow it. Second, please fill the survey on exit for today's webinar. The feedback is super important for us. You would also be asked in terms of like which topics you would be most interested to follow through, and it does impact our planning. We see like which topics are included most frequently, and then try to organize them. So please do fill in survey on exit. Then in terms of what's next, we will email the full presentation, the full report, sneak peek of which Charles has presented today to all participants of today's webinar. We would put it online. If you are interested to participating in the next round and would like to be invited, Please share your contact details already with us so that when time comes, we will invite you in a dedicated way. If you want to see what data requested, what are definitions so that you can align your data system, please also reach out now. And so then in the next round, it's a bit more complete. As Charles has said, we are very welcome for this interaction. So with this, I guess I have the pleasure of closing today's webinar. Thank you so much for active participation, of being engaged. I see many comments, many questions. I hope we were able to discuss some topics, and a big thank you to both Dr. Austin and Dr. Sandra and Charles for being our panel, and Zainab also for being our key speakers today. Thank you. And have a great day, rest of the day.
Thank you.